Hi there, and thank you for joining Delivering Successful Anesthetic Beyond What You Learned in Dental School. My name is Dr. Lori Trost, and I will be your presenter for this program. Just a little about me. I practice restorative dentistry in the greater St. Louis, Missouri area. I'd like to take this opportunity to thank those who are responsible for this program, Septodont and Viva Learning. I would also like to disclose that although I have no personal financial interest in any of these products, I am receiving an honorarium for this program. All the procedures and products used in the program are supported by the literature, as well as used in my practice. Just a few housekeeping points. This is a continuing education program. To receive credit for this, please follow the cue at the end of the webinar, and you can proceed on to the CE questions. Also, feel free to submit questions during the program if you have any. Just type those into the question box, and for continuity purposes, I'll wait to the very end to answer those questions. With this said, I'd like to consider this a privilege to share time with you, so let's get started. Even for the most experienced dental practitioners, consistent, profound anesthesia remains really difficult to achieve 100% of the time. It creates stress for both the dentist and the patient, and I know I've been there many, many times. It's extremely disruptive, and to a busy office or a busy schedule, it can throw you behind, and it's extremely frustrating, stressful, and sometimes you just lose the trust and the loyalty of the patient as well, and their confidence in you. So many times, really, in dentistry, what we're doing, we're performing a procedure that really is compromised just because that we don't have the quality of the anesthesia that we need or we expect, or maybe it's just not as predictable. So this program really is going to talk a lot about how we can make that better. Several studies confirm that right now, on average, 82% of patients have some form of anxiety when they come to you as a dentist. We've got to remember that patients are coming to us for an experience. It's just not always the treatment. And the crazier thing is, on the flip side of this, 84% of dentists inject 1.8 milliliters, basically one cartridge of anesthetic, in 20 seconds or less. I'm going to start by asking one simple question. Does injection speed help or hurt the patient? Does that lead to a good experience? Does that cause anxiety? There are multiple factors to really consider when you select a dental anesthetic agent. But even though several of these factors are out of our control, there's still a lot that can be done to improve the success rates. You know, we've got to think about specific procedures, the patient cooperation, facial morphology. What kind of preoperative pain did they walk in with? Do they have anxiety? Was there an insufficient volume of anesthetic in the area that we needed to have that reach that specific nerve? What about inflammation or infection? All of these things can greatly affect the efficacy of what an anesthetic agent and technique can achieve. Here's some responses from a professional publication that was done back in 2015, and I found this really interesting, and it just shows what anesthetic choices and trends are. And as you can see here, Septocaine, which is a trade name for Articaine, is the leader. Articaine has been available in Europe since 1976, but really didn't come into the United States and marketed until about 2000. But it has quickly become the #1 dental anesthetic we use today. The popularity that Articaine carries with it is basically attributed to its higher success of injection rates because it has a lipid solubility that creates a better diffusion through the tissues, both hard and soft. And it's interesting to note, too, that with this study, you can see here that respondents rated lidocaine in the 2nd position, and if you drop down to the 5th position of xylocaine, those are actually the same anesthetics. So this tells me there is confusion on the market today about what anesthetics are out there, and we can really kind of clear that up, and hopefully this program will answer some of those questions. Infiltration by nature is a supraperiosteal injection that anesthetizes the large terminal branches of a local area. But in large, it's really the easiest of all the injections that we do, and it's really limited only by the dense bone covering over the area that we need to make sure that it's numb. As you can see here, I like to use Articaine. It has a 1 to 2 minute onset. greater lipid solubility, like I just mentioned earlier, and you have a very profound pulpal anesthesia for a good 60 minutes. And by comparison value, this really, I think, plays out nicely for a myriad of restorative procedures and things like that. And we'll go into that in just a little bit here. But articaine is also known by other names, basically Septicaine, Orablock, and Articadent. We'll talk about those in a little bit here too, and show some of that here. But bottom line is, articaine has a great presence because what it does is it's metabolized in the serum plasma of the cholinesterase. It has a great comparison value to lidocaine in particular because it is 4 times more lipid soluble. And what that means is it gives it a better onset. It arrives at that nerve and is able to anesthetize that because of how it diffuses easier and better. And it also has a very high degree of safety, especially with patients that have any kind of hepatic disease. So this is a really, it's a solid choice, and it's just a very good, I think, great anesthetic on the market. I've been using it for a long time, and really it's something I use every day, and I can tell you patients really have benefited from it, and I know my dentistry has benefited from it because I can really rely on it. It's a good, solid choice. Let's look at some comparative studies here. From a meta-analysis of 13 clinical trials, the evidence strongly supports that articaine's superiority over lidocaine is really there. And you can see here in this first study, articaine is 3 times more likely to yield pulpal anesthesia than lidocaine. So again, articaine is going to be my go-to, and especially for infiltrations. It is a beautiful anesthetic to really arrive and diffuse and really get that patient properly anesthetized to do the procedures I need to. Here's another second study here where it shows articaine is significantly more effective as an infiltration anesthetic than lidocaine when used for teeth that are diagnosed with irreversible pulpitis. Again, this evidence is very strong. These studies are very supportive of showing you why this is an excellent, excellent choice. Personally, I do rely on Septicaine every day. That's my choice. I like the faster onset. It provides to me a very predictable and comfortable anesthetic for my maxillary procedures, and along with many mandibular procedures. And I'm going to show you and share why I choose it to use that. And it's interesting how with the COVID situation, how our schedules have modified, maybe how you see patients now, how the flow, the workflow is within your practice. And I just know that right now, to be respectful of PPE, how we sit with patients, if I can go ahead and place a topical, if I can go and wait approximately a minute and a half to 2 minutes for the topical to work, I can rely on Septicaine to go in and be infiltrated. I know within 2 minutes I'm ready to go, and I've got my burrs or my armamentarium ready to roll, whatever we've needed to do, impressions, scans, you name it. In that short period of time, I really can start to work quickly on that patient, and it allows me really to get onto the patients and keep the focus on the patient and get the procedure quicker. And I feel, honestly, it's a time savings to work with this kind of anesthetic, and it is a game changer. So again, restorative general dentistry, you can see here crown preps, class 1s, class 2s, scaling, root planings, even extractions. This is a really great choice to use. And often I'll use only a half of a cartridge here for certain procedures that you see here. And the patient's super comfortable. Lasts, like I said, pulpal anesthetic for, usually you can rely on it usually around 60 minutes. Even for a cartridge, a full cartridge, and super comfortable. By the time you're really done with your procedure, the patient's already starting to have some feeling come back, and they can leave. And it's just a great, again, good, solid choice. Articaine is also, like I mentioned earlier, great for mandibular anteriors and bicuspids. I find that the infiltration ability with this product is excellent. And again, in comparison to lidocaine, it is a winner. It comes out on top. Plus, it has a faster onset. Here's a tip that I found when I was in dental school. We were never taught to ever really inject lingually, and I find myself now on occasion, again, for scaling root planing reasons, sometimes even extraction reasons, other areas, sometimes we just have to really make sure that we're profoundly numb. Infiltration is excellent on the lingual with articaine as well. So this is a solid choice, and it does work, and it does work well. Let's talk about some of the different types of blocks that are available we can do and use with different types of anesthetics now. And I know this is a really good kind of a review on anatomy, but anesthetic has changed a lot over time, plus our knowledge of how we can use the different anesthetics with the different blocks. And is, again, really important, especially today as we move post-COVID, how we have to modify what we can do on patients and to get them comfortable and to be able to make sure we can do adequate quadrant dentistry, because to break down a room now is more cumbersome. To schedule patients, when a patient's in now, we want to maximize the time that we have with them and the focus on them. So I found that really learning to master some of these different blocks is really a great benefit for them and for me and for my time savings. So, and for care for the patient, really, that's the bottom line. So this is really a great choice here. One of the injections that I've really found here, you can see the AMSA, the anterior middle superior alveolar. This is from a buccal approach here. This is a great one to kind of revisit here and review the anatomy and how to do this. But effectively, this anesthetizes the anterior teeth and the bicuspids, and it's great for restorative work. A lot of times I'm doing quadrants up in the bicuspids or the canine region. I'll go ahead. You can do this bilaterally as well, and you need a short needle to approach this. Position a third to a half of a cartridge, so you're really not going to really extend very much into the patient, anesthetic-wise, loading dose-wise. It's a safe. Again, a great safe technique, but learn to master these techniques, because these are really game changers for how much dentistry you can do, along with for hygiene and for like scaling and root planing, basic things that we used to say infiltrate on every tooth. You don't need to do that. If you can master certain specific blocks, it's far better. So again, you're going to palpate the inferior orbital rim, and you can drop down about 10 millimeters. You can go there at that point in time. Also keep parallel and make sure that you know when you're doing these injections that you're staying parallel with the long axis of the teeth, and have your fingers in place and really just learn how to palpate different foramen. And once you place it, another little trick you can do is actually just rub over that foramen or that area, and you're going to find that that's going to help flow that anesthetic into that position of the foramen really nicely, and really gain profound anesthesia pretty quickly. Here's a palatal approach for the same kind of type of injection. The only difference with this is there's no lip or facial anesthesia that you're going to follow with this. So this, again, is very reliable for bicuspids, and I found this to be just a super good, again, just a great game changer. This is a little more difficult to achieve, and I'm going to show actually this one on a video here in a little bit, but what you're going to do is you're going to sight the midline of the palate, and then you're going to trend over midway up and go in and bisect where the bicuspids are, and go into where the areas of the midline. You're going to drop down below the interproximals, and the base of the curve of the lingual area where the fixed tissue is where you're going to place that injection. So again, review your anatomy, practice on this, but I think these are, again, are just terrific blocks and different injection techniques to use, and really, again, maximize the time that you have with patients and really keep your patients comfortable. And I'm going to show you some ways that we look at palatal approaches and we think, oh boy, we cringe. But honestly, it doesn't have to be that way. And I'm going to share some of those reasons why here in just a bit. If you're like me, you've had spells where you have missed mandibular blocks. So let's go to the big ones here, right? More often than usual. And this is honestly very frustrating. Like I've talked about, it throws your schedule behind. We all know that. You kind of lose, and the patient can lose trust with you. They can question what's going on. And honestly, you're sitting here, do I need to change the method? Do I need to change the anesthetic, what I've just delivered? Do I need to infiltrate or supplement? What about the anatomy? Did I really aim correctly, or did I have my landmarks really sighted properly? So these are all questions that really come forward once we have missed perhaps a mandibular block. And these are everyday questions that we face in everyday patients. And there is a wide variance in reported rates of failure in mandibular anesthesia. So honestly, the numbers are incomparably as high as 48% in some of the literature, which is pretty astounding. That's like almost half. So rather than beat yourself up. It's just about really the clinical reality is this is problematic for all of us. And regardless of how much experience you've had, what you're using, how you're doing it, variations happen. So, I've learned over the years when this happens, I just really need to go back to the basics, and I really need to ask myself and review my technique. I need to think through what I'm doing, how I'm doing it, and going about it, looking at the anatomy and looking at the science, the science of what's behind what I'm doing, how I'm going about it, and really make a proper choice moving forward. So, and looking at how the time is, because sometimes we have missed a window of time, or perhaps we could have maybe had the patient open just a little bit longer, or maybe be angled a little bit differently. That makes the world of difference. So, to review some of these blocks that we do mandibularly, you have an inferior alveolar, you have a lingual, a long buccal, the mental, and the mylohyoid, as well as the lower two I've mentioned here, the Gaugates and the Akinosi, are two that I'm going to focus on tonight in particular. So the first five that I've listed, from the inferior alveolar down to the mylohyoid, these are basically blocks that are an incomplete block. You're going to have to supplement another injection in order to make sure that you have proper anesthesia. So an inferior alveolar block by itself is not going to provide the adequate, proper coverage of anesthesia, say for a lower quadrant, okay, for say a second molar type procedure, okay? I'm going to show you why in just a little bit here too. However, when you go to the Gaugates and when you go to the Akinosi, those two are a complete block. There are no additional, when they're done correctly, there are no additional nerves that require anesthesia. So I'm going to go into that in just a little bit here, and I'm going to show you why. So mandibular block success. A traditional type of comparison technique that we've used in the past, you can understand why certain blocks now work because of anatomy. And as you look at how these nerves are labeled here, what we were taught in school, and again, this is always a great refresher to look at, but traditional inferior alveolar type blocks only gain about 65 to 80%, 86% success. So that's, to me, not maybe as great as I like to have. I want to have something that is more dependable. If I go to the Akinosi, which personally I'm not a big fan of because it's more of a closed mouth technique. Now I do know, and I have colleague friends who are excellent at this technique. It's beneficial for patients because it's more of a closed mouth technique. And all of us have patients who have limited opening. They might have TMD. There's a variety of things that really necessitate making this a good choice. So this technique I'm not going to really super focus on right now, but I will mention that if you look into it and you find that you have patients that really qualify for this and necessitate this type of technique, learn how to do it and get some, read up on it. And again, let's go back to the practice and look at the anatomy and really gain a good understanding of how to do that. But my preference is a Gaugates, which honestly yields a 90 to 100% success. And the reason is because of exactly how the ramus, in the length of the ramus, where the nerves are exiting out of the foramen, and where the deposit of the anesthetic can be, and the length of where I'm reaching and feeling, and what I understand dependably about where I can deposit that anesthetic and how I can make that flow into that specific area. So again, you got to keep in mind that you really want to make sure that you have a single injection, honestly, often is just not going to be enough. You might have to supplement, and you really need to think about, if I have to supplement, do I have to do a lingual or a long buccal or sometimes a mylohyoid nerve? So if you're doing a traditional type technique, that's going to have to be the question you ask yourself. You're going to have to be guaranteed pretty well doing a supplemental type of anesthetic, okay, injection. Again, like I talked about, Akinosi is not my favorite, but Gaugates is, and I really will focus a little more on that today for a couple other reasons too, and I'll show you in just a little bit. Let's look at a little bit more of anatomy and the variations that appear on, of what happens with where the mandibular foramen is, because that's really what our major landmark is that we rely off on. So the goal of any mandibular anesthetic right now is to bathe that area and get the sufficient length of that inferior alveolar nerve to be covered in some type of anesthetic. So therefore, it's going to anesthetize and do what we need it to do. But you've got to achieve this with getting that volume of the anesthetic into that area to make sure it covers those little 3 nodes of Ranvier. I'm sure many of us remember that, right, on that target nerve. So to really make that happen, we've got to have a predictable method that we do this, and we've got to have at least 5 millimeters above that lingua where the nerve enters the ramus here and the mandible. We got to make sure that we're having that anesthetic in that area. And so the reason I'm showing anatomical variations, it's really important because the mandibular foramen location, 75% of the time, it's below the occlusal plane. And if that happens, that means if we're using the occlusal plane to be a measurement of how we're going to place this anesthetic because we think we're sighting that, we're going to really be missing that area. And then again, 22.5% of the time, it's even with the occlusal plane. So again, our landmark is there's variations here, and we need to learn to feel that. And patients, no patient is the same. We all know that. And we really need to understand, again, anatomy. We need to understand where that anesthetic needs to sit at, and understand how, when we're maybe using that bisection technique, where we're approaching maybe from the contralateral side, from the bicuspids and the canine, and move more anteriorly, we can slip that back and feel where that is going. That landmark is totally a cornerstone, along with this occlusal plane, along with feeling the ramus. And we got to think about, too, the flare of the ramus, all of those things, too, tongue size, posturing, how the patient's sitting. There's a lot of just contributing factors. So variations happen, they're real, and don't beat yourself up because everyone is different. And now you understand maybe why only 48%, 50% of the time things are working or they're not working. So there's your response. That's exactly what happens. Here's something that to me is very, very critical too: positive aspirations. And when you look at what happens when you inject, we all need to make sure we're aspirating. We need to use a good syringe that allows us to aspirate, good technique. But traditionally, on that type of regular inferior alveolar injection, you're going to have anywhere between 3.6 and 22% of a positive aspiration. And that's a pretty high area. And we really want to avoid any kind of major vascular interference, because we know that's not good for our patients, certainly not good for us, period. So if we can avoid that, that's really key. You need to make sure, again, go back to your anatomy and review that anatomy. Seriously important. Gal gates here, again, if you're going in that position that's a little bit higher that we just talked about, you have a less chance of getting into that vascularity. So you only get a 0 to 2% chance of a positive aspiration. So I like the idea of the Gal gates has an extremely low chance. Again, that to me is a good choice and a good technique choice for my patients. And you can see likewise here for the echinocele, that has a 2% chance of positive aspiration as well. So I think those, again, are very important considerations. You need to make sure you're aspirating, and you need to reposition if you have aspirated, making sure that how you position your needle or your injection changes, because that's very, very critical. Let's talk a little bit about the inferior alveolar block that we talked about earlier. It is definitely a incomplete block, mainly because it's going to anesthetize the portion you can see here in yellow on the diagram here on the left. And bottom line is the lingual nerve block is going to be given in combination, and often you have to do a separate injection of a long buccal to get the buccal aspects of those molars to work on. So like a second molar crown prep, you're going to have to do a supplemental injection no matter what, just because by virtue of the anatomy. So again, think about what your choices are. And really review this. Honestly, if I can just do one injection and be done with it, that's my choice. And I think we all want that to happen. But again, if it doesn't, you have to understand, how do I re-inject? What do I need to change? Here are my considerations. So hopefully this is giving you some good food for thought. Here's some really interesting, I think, science behind what we do here. Here's a study that compared 4 techniques in those that had a failed inferior alveolar nerve block with lidocaine. and they went ahead and they used articaine. And what they did was they did a supplemental, okay, injection. They did a second inferior alveolar nerve block, and they only achieved pulpal anesthesia 30% of the time. That's only a third of the time. That's not great in my estimation. They went on, moved on to a PDL, okay, periodontal ligament, basically injection. They were getting 50%, but those are often very painful. They're uncomfortable. As a female, I have a hard time really squeezing myself that type of anesthetic into that space, and that's a difficult injection for me to give. So it really personally is not my choice. Another situation here, you can see, again, comparisons. And long story short, if you look at using articaine as a buccal infiltration method, 84% of the time, they were able to get successful pulpal anesthesia. That's a very, very, I think, high number, and a very good lean to and go-to choice if you're not getting anesthetic where you need it to be. So infiltrating with articaine is a great, great choice. So keep that in your toolkit. That's a good thing to remember. If you're going to do Gaugates, let's talk a little bit about that technique, because I think, again, always reviewing anatomy is so important. Very, very important to understand this is a technically difficult and more difficult, honestly, injection than others, but it yields a better outcome. You've got to make sure that you feel for the width of and the length of the mandibular ramus. You need to keep your index finger behind the neck of the condyle, and you need to assess your grip and start to feel that length and the width, and really hold that. And usually what we're talking here about, the length of that ramus is around 25 to 28 millimeters long. So for that very reason, you need to select a long needle to give this injection, okay? Don't let that scare you, but that's just what you need to do. If you use a short needle, you're going to be short of where you need to deposit that anesthetic. So very important to do that. Shorter needles just don't reach that space or that area. And then you need to start considering the medial and also the lateral angulation of the mandible, how it flares, and you can start to, again, feel that and make sure that patient stays very wide open. I like to really hold my thumb distal to that molar, and I feel that curvature of the of the mandible. I feel how that ramus is, and I keep my hand, and I'm really feeling that all the time, just to really make sure that I've got a good sight on that. The next thing that I want to do is I'm going to go ahead and sight off of the second molar, the maxillary second molar, that distal buccal cusp, and I'm going to go ahead and do kind of bisection angle. I'm going to go across contralaterally, and I'm going to go ahead and really sight off of that distal buccal cusp, angling from the opposite side with those bicuspids. And as I go to that, I'm actually angling towards my index finger, and that's where I'm going to insert and place my anesthetic and enter the tissue in that area there. Very important that when you're holding the mandible at that point in time, and you want to keep that patient really open, it's important to really extend that mandible really nice and firm with your hand and keep that grip going, because what will happen is the inferior alveolar nerve will become more taut, and because of that reason, once that patient closes, then as you stretch that nerve, the anesthetic has a better ability to flow into that space, and really it will relax, and it'll move distal to the side of where the injection is, and you'll get a better outcome. So that's a really great tip. Keep that patient really nice and open. Keep that nice and taut, because that will help that flow and get into that space much, much easier and better too. So I think that's really a great tip, and a lot of times I try to get in there as quick as I could. And it's a different kind of technique. You've got to really keep that mouth open, really keep that mandible nice and wide, and feel that area. Here's and I think to me one of the biggest keys that you can do. You've got to make sure that you inject slowly. And as you aim for your index finger that you're holding back behind the ramus of the mandible, you really want to insert the needle slowly. And you want to keep your steady aim. You want to keep this very controlled. And honestly, studies show that the slower you give an injection, the more accurate you're going to be. And I know that we're always in a hurry. We're always trying to make it happen. But making anesthetic and achieving really successful anesthetic requires a much slower approach, because you're going to get a more profound result, a better patient experience, and quite honestly, you don't have to you just don't have to redo things as much and really guess what you're doing may be wrong. So maybe a failure could be that you're doing the injection too fast and it's really throwing off your accuracy. So again, just tweaking little simple things like this do make a huge, huge difference. Very, very important. Here's one of the keys too that I know and that I've come to understand. Really make sure that patient, I'm going to go back to this a second, make sure they stay super open. I like to split the difference too with where I'm holding the ramus and the mandible here. I like to take my thumb and my index finger and I look at those occlusal planes. I'm really aiming between those, and once I've hit the ramus, I'm going to pull back about 3 to 4 millimeters, and I'm going to begin the injection. That's where my aspiration aspect happens. And again, it's just safe, it's slow, it's more accurate. So I'm comfortable with doing that, and this is a technique that I've really adopted, and really I feel that I've mastered it. Again, I have frustrations sometimes because I don't always get it, but more often than not I do, and it really helps, you know, to proceed quicker with an easier flow of your daily schedule for sure. So one of the things too, I think you need to inform, I know often in the past, we've anesthetized patients in practice in the past. If we had multiple operatories, you're going back and forth, you anesthetize, you go away, you know, you're waiting, your assistant says, yeah, they're ready. Well, I think with COVID now, we're all rethinking how we have a workflow within our practices. So one of the things that's, I think, very, very important is to understand how long does good mandibular anesthetic take to onset. And you need to really work with your assistants so they have a good understanding of where the patient needs to be feeling numb. And often, you know, quickly they'll say they'll feel the side of their mouth. Well, no, in the corner of their mouth. No, corner of their lip. It needs to be out to that midline, and that's where you know. So if you look at this comparison here with a traditional type of inferior alveolar approach block, you're going in 5 minutes, you're going to be pretty well 72 to 85%. But again, that rises within 10 minutes. So you see how that anesthetic starting to flow in and really bathe that nerve to make that happen. What's interesting, at 5 minutes for a Gal Gates, you're only at about 45%. That's not a great high number. I need to wait about a good 10 minutes, and that's a long time to wait. And I know many people say, oh, I don't want to wait that long. Well, here's the thing. If you're doing that technique, and you're going to understand, you don't have to then go back and supplement. And I think that's really important to understand, that you don't have to repeatedly inject, and you gain the confidence of that patient. And I think just good technique, you're able to really focus on the patient, wait that appropriate time. It's not the 5 minutes you're going to be waiting, but you're going to be waiting basically the 10 minutes time, and then you're ready to start going. So keep that in mind. At 5 minutes, you're not quite ready yet with the Gal Gates. So don't beat yourself up that they're not quite numb. It's just maybe you just haven't waited long enough yet for them to get numb. I'm going to talk about control, because anything we put in our hands, whether it's a handpiece or extraction forceps, you name it, you've got to have control, and a good control. And it really is true for obviously anesthetic syringes. So it's really critical to feel what you're injecting through muscle, tissue, hopefully not a gland or something crazy, or a vessel. But bottom line is, many of us, and I went through dental school thinking that all syringes were one size and they fit all, and that's what you had. But coming out of school and really getting into practice, it's quite different. And you can see there's some really great syringes and sizes out there. Honestly, this is a comparison of my hand and a colleague's hand. I have a size 6 hand, and my colleague friend has a size 11. And you can see completely different grip size, ring size. Here, is a standard, in the bottom picture is a standard syringe, and you can see here my thumb literally is just so loose in there. I have no control. It's spinning around on me, and I really don't care to even, I don't want to use a syringe like that. So I found that the petite syringes by Septodont excellent choice, especially for smaller hands. And try these things out. Have your reps talk to them, see what you can use, see what you can put in your hands to make it feel better so you have more control. But this is a small change that you can really up your game, and again, really become a lot more astute at just the control and the feel and the carefulness that you're able to use, and really just really make it a much better and easier fit. And it's easier for you too, because it's just a great tool and just a method that you want to adopt. Speaking of control, there are several different types of anesthetic delivery systems that are now out on the market today that really do help us as clinicians with the flow of anesthetic. They work with the volume and the speed of the injection through types of different automated or computer-aided designs. So there's a variety of these different gadgets on the market today. Many of these units have different sizes, different footprints. Some have cording and tubing to them. Others have foot pedals. Yet others need dedicated needles to work with within their systems as well, and that complement their systems. But regardless, these are really a step up for many of us who want to get into that painless injection thing, which I truly believe if you are able to give painless anesthesia, it is a practice builder second to none, and it will spread the word like wildfire when people know that they can get anesthesia and it doesn't have to hurt. It doesn't need to be like that. So I just feel these gadgets are amazing. I think they help us just do much better dentistry. If our patients are comfortable, we can certainly do terrific dentistry. This is the neatest, I think, addition to the market today. This is the DentaPen by Septident. It's a computer-controlled local anesthetic delivery. It's a very light handpiece that has and offers either like a pen-like grasp. You can even use like a traditional and hold it like a traditional type syringe delivery as well that we're used to. So I just believe that the control this gives us, because this has a pressure and volume and time component to it, it allows us to really focus on what we are aiming to anesthetize, and more importantly, kind of really just does the job for us, and it really simplifies everything that we do as far as anesthetic goes. It's really a great gadget. I really like this tool. What I also like about it, it allows me to have better, I think, insertions, better positioning for the patient. I found that the visualization when I use a gadget like this is amazing, but DentaPen is really neat. It also has an auto aspiration feature, which I think is extremely unique and really just works to complement this whole system. And I'm going to show a couple of videos here in just a little bit of how I use this within my practice. But I found that patients really, and I'm using this on the videos too, on some patients who are very anxious, and they've done extremely well, and they had very good experiences, and I just find it's just simple and easy to do. Here in this video here, I'm going to go ahead and assemble this. You can see this weighs basically 1.4 ounces here. It has 3 batteries that it comes with. I'm loading the anesthetic of choice into the cartridge here, and we're going to go ahead and use the finger grips here to secure in place. There's the on-off button, and here I can insert my needle for that assembly, and I'm ready to go. It also comes with sleeves that for infection control reasons that cover the unit itself. There's no cords, that simply turn it on and you're ready to go. And you can press that little black finger grip right ahead of it for a pen-like grasp, and you're ready to anesthetize. So this is a really simply nice gadget. I think it's a great winner. It has 3 different modes and speeds and 2 different injection modes. I just really like the design of this, and I just think it's really a nice choice to add to your armamentarium. And I think with this in complement to different various palatal blocks that you can give now and use and really benefit and maximize it, again, that time for patients, this is a true win-win. So here's a couple of neat things. Once you've turned the unit on, you're able to gain a button that you can select the speed and what you want the anesthetic to go. So purple obviously is for fast, for Galgates or inferior alveolar. You're going to be giving 1 milliliter for about 30 seconds. of time. And again, this just flows it in, and you don't have to push anything. You just hold the unit, place it correctly. So you're really focusing on the needle insertion, the position, the anatomy. You're not having to squeeze anything. And I think the control that it provides is really, truly amazing. For the blue level, if you select that, that's going to be a medium for infiltration. You're going to have a milliliter of anesthetic that's going to be delivered over 60 seconds. And that's really a big gold standard. I know Dr. Malamed, that's what he recommends. So that's a really, to me, important benchmark that we should always gauge our injections by too. And for a green setting, which is going to be slow, you're going to use that for the palatal injections, for a PDL, even for a buckle, a long buckle. So those are, again, good choices. Smaller anesthetic amounts, but you're going to a longer period of time in which you're going to inject and use that with. So that's exactly how that works. And simply put, here's what this DentaPen looks like. And you can see here I've got the sleeve covering the unit. The unit itself is not autoclavable because you don't need to because of the sleeve. However, the cartridge and the finger grip are. You can see here I've used a topical agent on the patient and selected the speed here. And literally I'm just focusing on just inserting that needle carefully and nicely, and simply I'm doing that per the bevel for the tissue and how I insert that. And you can see here I'm just press the button and we're going to go ahead and deliver that anesthetic. And if you look into that cartridge, you can see how there's a little piston that will drive the anesthetic and put the anesthetic in at the set amount of time. And you can look and clearly sight that as you're giving the injection. You can see how much you've given. And simply put, it's very small, easy, fits in my hand great. I think it's a great win. And these patients, once you've used this, they're like, wow, I just don't feel any, this is terrific. I mean, they really have a noticeable experience that they remark on it. So it's a practice builder. It's a game changer for, I think, for anybody that uses it. Really nice tool. You can see there how the piston's kind of advanced the plunger there. I'm repositioning here and doing a little more infiltration distal to this, but you can kind of get the idea and the gist of how this works. Again, slow and comfortable, and you can achieve great anesthetic within 2 minutes. You're ready to get going on your procedure. So I'm using Septicane here, and there we have it. What's interesting is often, I have people that say, do needles make a difference? And that's another thing. We talked about the speed, right? Yes, speed does make a difference. We know that. Faster injections are not good. They're painful. Plus, they're not as accurate. We know that. But needles, do they make a difference? And the answer is an easy answer, because simply, if you start to look at what we've been discussing, if you have to do multiple injections, and if you have to do supplemental sites, okay, you need to start thinking about how we perform quadrant dentistry. And in the reality of everyday dentistry, what do you consider when you select a needle? Are you looking at just at the gauge and the length? Are you looking at, do you consider sharpness? Do you consider the quality of the needle? What about securing the hub? I know not long ago someone had said, you should try these needles because they really are cheap. Well, cheap maybe is not always the best, because here's the thing, it doesn't secure the hub, and it had more of a plastic or a metally grind, and I was having to just work with my syringes and cleaning them up all the time because it just didn't secure it correctly. So again, quality is really paramount when I think you're choosing a needle, because you want to have something that if you in fact have to use it multiple times, you can with security and with confidence, because it's going to work once well, twice well, 3 times well in case you need it, because you've seen proof. Now, we do have to do multiple injections often. Also, shelf life on needles. Make sure that you're paying attention to that. It's kind of funny to say there's maybe expirations, but there is a shelf life, because many of these, how they're manufactured, have that listed. So make sure your assistants or exactly what that says, how long that can work and be effective. So needle comparisons here. As you can see, not all needles are identical. Obviously not always in design, but also in the manufacturing. So, a sharp needles can provide less tissue displacement. It's going to definitely reduce the patient's discomfort. So tissue displacement is really, it really relates to how that needle is inserted into the tissue without any drags. And in the comparison here on these different photos, you can see here, there's barbing going on, there's drags going on. And think about, again, if in fact you have to re-inject, this is going to displace this tissue differently. It's going to pierce it differently. It's going to be felt and really experienced differently. So, and then you think about, in fact, if there's any nicking of a nerve, and I hate to talk about that, or any of the vascularity that we come near often. Again, if you don't have a really quality needle, you might be inviting more problems than good. So you need to make sure that you rely on some type of needle that's going to have a good quality design to that. And honestly, I like to use a needle that has a triple bevel design. And you can see here, this is a scalpel design. It's a Septidont Evolution. It requires less insertion force, easier penetration. It comes in a multitude of sizes here, but honestly, when you can say that the fourth insertion still has less force needed compared to a standard needle, that's pretty significant. So I like choosing and working with a needle that I know if I have to use it again, it's going to work as well as the first time. And to me, that's very, very important. I mean, no pun intended, but I personally stick with these Septidont and Septiject type brand of needles because they work and they have quality and they have precision. And I think they're just a great thing to add to your armamentarium. I'm going to show here a little video here. I'm using the DentaPen, and I've got an Evolution Septiject, I should say, rather Evolution needle here I'm going to be using. That's bottom line, it's a 30 gauge needle. It's a short, it's basically a 10 millimeter needle here, and we're giving an AMSA anterior middle superior alveolar injection in the palate. This patient, honestly, very, very apprehensive. I like to take my fingernail and actually kind of push into the palate. I have the setting where it's going to go ahead and just drop probably about a plunger's amount size of anesthetic there. You can see how we've done that. We'll kind of sped it up a little bit, but you can see the tissue blanching here from the DentaPen, and that patient did extraordinarily well. Again, the DentaPen afforded me that, a good needle afforded me that, and a great anesthetic afforded me that. So I like all of that combination. That works extremely, extremely well. When you look at different needles too, again, consider not only just the design of the needle and the bevel, but more importantly, the Septiject, the XLs on the 27 gauge needles, which again, for inferior alveolar, these are excellent needles because they have a 43% wider opening. So what that really translates to is it's going to be less pressure to inject. You're going to have the ability to flow easier into the tissues. Now you may say that, oh, that's going to make a faster injection. No, it doesn't. It just makes a less resistance in which you're going to flow and less pressure in which you're going to flow that material in, so that anesthetic in. So this is a great, again, a great choice. If you haven't used these, I would try to get a sample and really see how they work well in your hands. You will definitely tell a difference because there's less fatigue as you press, and it just really makes a much easier penetration and flow of that anesthetic into that area and that site you need to have anesthetized. Let's talk about some practical insights. Really important to make sure that you always review the patient's medical history, and work with your team members. It starts at the front desk. Often now we know for sure it starts even before they walk in the door. So we've got to make sure that we're having good communication, whether you're using different patient communication systems. Within our practice, I use Weave. I love it. It works extremely well. But we have patients answering questions before they even step out or get out of their car to step into the office. And it starts with any changes in your medical history, any kind of new medications, and you really need to come out and ask them specifically what they're taking, if they've had any surgeries. Often patients think that these outpatient surgeries or joint replacements are simple and easy, but they're a big deal. And we need to make sure we record all this. We need to make sure that we take our patients' blood pressures along with, and we are doing this now, but we're doing pulse ox on all our patients now with the COVID. And I really think that's a great thing to add into your armamentarium again. So make sure you take review the medical histories, take their blood pressures, because often we're going to see the patient more than they even see their primary care physician. So a really good connection and a great, I think, benefit to the patients and a good service to them as well. Practically, topical anesthetics are very, very important. There's a good variety of those out on the market today. I can tell you right now, any of these work well. The key is just to use them. And I think, honestly, we find that many topical anesthetics just are runny, or they just don't work well. One, if they're runny, they're not staying on the tissue. You need to dry the tissue. You need to make sure they're staying placed. You need to apply them correctly, and then you need to wait the appropriate amount of time. And often that's usually around 2 minutes. So again, use topical. And what I find is interesting is I think 35 to 40% of dentists use topical. The other ones don't. And I think that's kind of crazy. So make sure you dry the tissue, apply it, and then wait. Topical does make a difference. When you are assembling your syringe, you want to make sure that you load your anesthetic cartridge first, and then you're going to insert the needle into the hub and secure that correctly and twist that and make sure that is completely even and level. And then you're going to take and engage that cartridge by just kind of popping the end of that syringe, and that way then the plunger is active and you're able to see where the bevel is to orientate your needle for insertion. So that is the correct way in which to load a syringe. Another trick I've learned over time, tap on the patient's shoulder. You can have your assistant or even your hygienist, whoever's around, they can tap on the shoulder. And what this does effectively, it challenges the gate theory of pain. So patients will feel the tapping. They think it's distraction, which yes, it is. But more importantly, their brain and their neurons are going to feel more of that tapping sensation versus the pain initially. So that's a great tip to do. And I've been doing it for years, and it does work. It's wonderful. For palatal injections, obviously we all cringe when we think about palatal injections, but a couple good little tips I've learned over time. You can use an apply endowise. You need to make sure, though, if you're going to do that, you need to be very careful not to do too much, because you don't want to damage that palatal tissue. So that's one choice. Personally, I like to take a little bit of anesthetic. I will drip a drop or two on the palate. I will take my fingernail and push into the palate a little bit, and I'll place the needle as close as I can to the palatal tissue. And as that rises, my fingernail releases, I'm able to insert the needle and do the palatal injection. Another tip I've learned is mepivacaine, since it has a very even and level pH, is a great choice initially to anesthetize on palatal injections with. So that's a really good choice. It doesn't last necessarily as long, but you can go follow that back up again, perhaps with another injection, perhaps like articaine or something, or septicaine. That'll work nicely for that, to follow that injection for the proper amount of anesthetization. Tips for kids. You've always got to use topical. No matter what you do, you have to use topical, and it needs to stay dry in there and it needs to stay in place. I love to use mepivacaine initially for children, because it has that ability to, it has a very mild pH, so it doesn't have that stinging sensation that can be picked up into the tissue. It's not as acidic as the others. Once they're anesthetized with the mepivacaine, I just give a small amount, maybe a third of a cartridge, a carpule for that. I'm going to go ahead and follow this up with articaine. And if I have to, say, for example, do an extraction often, I'll go ahead, I'll inject into the papillae, and then I'll move around palatally with the articaine to get that area properly anesthetized. I can also inject into furcations with this as well, with the articaine, and find that works very nicely. And it's a great, safe, obviously, anesthetic to use for kids as well. So just, again, know the amounts, and we'll know the pounds. And we'll talk about dosing here in just a little bit. For geriatric patients, a couple of things you need to keep in mind. First of all, many of them have reduced organ function. So you've got to think about what your anesthetic choice is. And you always need to ask about their kidney function. That's really critical. So to know ahead of time, articaine is a good choice for patients with any kind of questionable kidney, lack of kidney functions. So again, a good, safe choice, good for kids, good for geriatrics too. The other thing with anesthetic on geriatrics, you need to make sure, because they have a decrease in their total body water and their lean body mass is less, you're not going to use near the amount of anesthetic. It's going to be metabolized differently, quicker, and less is better for them. So again, cite what you're going to do, really match the procedure, the amount of anesthetic, and use proper delivery, and that will work very well for you. Let's talk about some troubleshooting and reasons for failure for different types of different perhaps blocks. And mainly it's the biggest one we look at is mandibular blocks. What are we doing? So the anatomic variation is really important. And honestly, I've had a number of patients that I just couldn't get numb to. And you have to, again, go back to the basics. Look at your injection technique, patient anxiety, inflammation, infection. Maybe your anesthetic could be even expired, so be careful. Another thing I've learned over time, smokers, they really are difficult, honestly, to get numb. And the reason is smoking changes the liver enzymes and increases the blood flow and causes a faster metabolism of that anesthetic. So I routinely now ask patients who I know that smoke not to smoke 2 to 3 hours prior to their appointment, because it can throw a wrench in, and it's nothing worse than having a bad appointment with a smoking patient. Honestly, so if they can just calm down, not smoke for a couple hours, that's going to really benefit the procedure, and you're going to get a much better, more predictable anesthetic experience. Infections can be tough, and they're tough to deal with, and no matter what you do, you've got to understand that infected tissue is always going to be more acidic, and inflamed pulps are very much more difficult to numb for that very reason, because you're thinking we're putting acidic on top of an acidic situation already. So what can you do? What's your go-to? What if you have a patient that has an infection? What do you need to do? So for the best results, what you're going to want to do is look at and selecting a local anesthetic that has a better binding ability, better lipid solubility. So that's going to be your Articaine, your Septicaine. That's going to be your go-to. You want to have something that has a good diffusion rate to this. You're also going to go, and when you inject, you want to place that anesthetic away from where the inflamed tissue is. So for example, if you have an infected, say, premolar or molar, you don't want to go locally and infiltrate just around that area, that tooth. You want to give a block, because you're going to have a better chance to get that numb, then come back and infiltrate. And here's a really great tip. Over time, and I've learned this too as well, and here's some great studies that prove this, but if you take a non-steroidal anti-inflammatory, they can actually enhance that role of an anesthetic. So they're going to help reduce that inflammation. They're going to be able to help you achieve that anesthetic level that you need to do your proper procedure. So hot teeth, let's talk about them. We've all had to deal with them, and again, we're back to that pH level and preventing that, which is going to prevent the disassociation of how that anesthetic is going to be able to flow into that area. But honestly, the Gal-Gates has the higher success rate versus these other types of techniques, and this is using a 4% Articaine, again, with 100% epinephrine. If the block injection does not work, again, you can go back to infiltration like we talked about here, the option, or you can also give a periodontal ligament or interosseous type injection. So again, go back to those techniques, drop back. If the block doesn't work, look at infiltrating, doing a PDL or an IO. Seriously, good tools to have, because we all have those kind of teeth, and those patients are miserable, honestly. They're tough to deal with. Reversing agents, I find this to be, again, a great adjunct to have in your practice. Terrific for kids, terrific for patients who have maybe early morning appointments. I know we do that often, but honestly, this is Oraverse, again, from Septidont. It is a reversing vasoconstrictor. It's a phenylalanine. What it does is it goes in as a vasodilator, and it allows patients to return to normal feeling within 30 to 60 minutes versus a normal, say, to 3 to 5 hours of time. So it's a great reversing agent, fantastic for kids, honestly, because it's going to reduce that soft tissue. and any type of injury, because we know that some people just will not avoid chewing or biting their lip or their tongue. So again, use your caution. So some of the studies again that prove how this works and why it works so well here. This was a study published in JADA, and the recovery time really is basically about in half here. It's pretty amazing here to see how quickly things can recover and be reversed. So if you haven't looked into this, read up on it and see how you can use it. It's a one-to-one, one cartridge and one cartridge or reverse, and it is again a great practice builder and a great adjunct for patients. Something I get asked routinely too is about warming anesthetic. And in the Midwest, I mean, obviously we're coming into colder weather here sooner, and warming anesthetic, I think, is a great thing to do, but you've got to be cautious when you do that. You want to be able to warm it to the body temperature, and we do know that it can decrease some of the patient discomfort, et cetera, and it needs to be maintained at a constant temperature. But you need to make sure that you don't use, and if you use a warmer, it needs to stay at a constant temperature. You need to make sure that it's not repeatedly heated and reheated, because that will actually destroy and mess with the epinephrine. So the vasoconstriction action of what you have in epinephrine is actually affected if it's denatured. So you want to make sure that you do not rewarm. If you're going to warm any kind of anesthetic, put it in there, use the one you need, and get it out of there. Don't leave it in there for a long period of time, and don't reheat it. Let it cool down, because that will really mess with the efficacy of what that agent is supposed to do. Everyday dentistry. So what are your practical choices? For a 1 to 2 hour procedure and most block injections, I think personally, here's my go-to. I'm going to use 2% lidocaine with 1 to 100,000 epi. For infiltrations and hard to anesthetize patients, I'm going to use a 4% articaine with 1 to 200,000 epinephrine choice. For longer procedures and procedures that need pain control, I had a patient today with a really tough situation, and bupivacaine was my choice, 0.5% with a 1 to 200,000 again epi. Really a great anesthetic to have. I don't use it real often, but on occasion it's my go-to. For shorter procedures, obviously, for patients who require that no vasoconstriction type of agent, bupivacaine, a 3% plain is going to be your choice. And then again, as I mentioned earlier, the Orverse for any kind of anesthetic reversal agents there. On pharmacology, some things to always keep in mind. There is no contraindication for combining amide agents or anesthetic agents, but you need to remember that they are additive in dose. So you should not exceed the safe dose for the agent with the highest concentration. So keep that in mind, okay? Very important. Also know that a plain anesthetic for a pre-injection followed up with an anesthetic containing a vasoconstrictor is absolutely fine. And like here we say plain anesthetics, so you're going to be looking at like your bupivacaines. They're going to be in that 6.5 pH range, whereas anesthetics with a vasoconstriction of that epinephrine are a lot lower. They're much more acidic. So always keep that in mind too. So you don't want to have that burning sensation. More of those epinephrines are going to have that and yield that type of burning sensation. When you calculate dosages, again, you can look at this. This is cartridges here. You're looking at the active chemistries that are going to make the poundage per the cartridge. What's the limitation of what you can do? And keep in mind, too, these cartridge volumes vary from 1.78 to 1.82. The bottom line here is you need to understand as you measure and calculate these, if you're looking at a dose for a lidocaine patient, you're going to have 150, say, pound adult. You can take that 2% lidocaine, do your math, come down through all that. You can understand how that works. Bottom line is 13.33 cartridges is going to be the maximum dose for any patient that you're going to anesthetize with lidocaine, which is going to be 1 to 100,000 epinephrine. For articaine, the same kind of dosing formulation you're going to use, again, with 1 to 100,000 epinephrine. The most you're going to use for articaine is going to be a lot less, and anesthetic cartridges is going to be 7.05. So make sure that you know where you're at with your doses. Always locate that, tally that, record that in your notes. Very, very important. A few things to follow up with. Any local anesthetic can cause some type of problem. You want to make sure that you never inject a patient if they're cringing. Make sure that if you have the chance that you hit a nerve or pierce a muscle, inject in the product, make sure you're documenting absolutely everything, because we need to remember that needle trauma is usually the cause of this, and really not the neurotoxicity of the anesthetic agent. It's the trauma of basically that needle. Very important to understand that. Some final things to talk about. I always make sure that you want to recommend you would always inject in a straight line. You do not want to bend a needle, because that can compromise the flow and the strength of that. You don't want to bury the needle to the hub when you're injecting, especially like on a Gal Gates, like we talked about earlier. And be aware that smaller gauges of needles are easier to break. You want to avoid a 30 gauge needle for a mandibular block as well, too. It's not as strong and as wide, and the gauge is not as large as it needs to be. So I want to leave you with a few thoughts. What defines success? Pretty well, you need to understand what the procedure calls for. Consider the specific patient. Use a proper and a good technique. Go slowly. Find your comfort zone so that you can do the best dentistry for your patient. So I want to thank you for your time in joining the program. And I know I pretty well have almost run over my time. I'm going to ask, if you do have questions, please forward them to trost@hcc.net, and I'll be happy to answer them personally. I thank you for your time. If you'd like to get a materials listing, you can also email me as well, and I'd be happy to share any of that with you. And for your continuing education credits, stay on for the queue, and they'll move you to that to answer your questions. Thank you so much. Have a good day.